And we are ready. Thank you for joining us for this presentation of the Dan River Health Equity Assessment. This assessment was conducted by the University of North Carolina, Greensboro Center for Housing and Community Studies. We're going to hear today from 4 of the researchers on our team. The team included myself. I'm a professor of sociology and director of the center. Dr. Ken Gruber, who's senior research scientist and assisted on the surveyed research design. Dr. Hayoung Soo, who's a data specialist, also assisted on survey research and some data analysis. Ms. Meredith DiMattina, who's our GIS specialist, who's on the call today to talk about the mapping of data that we performed. Mr. Bruce Rich, who's a research associate and research assistant director of the Center for Housing and Community Studies, who conducted much of the qualitative data collection. And finally, Dr. Erica Payton-Foe, assistant professor of public health at UNCG, who will talk to us about the impact of COVID on violence, community violence in the Dan River region. Process for this project was to review jurisdictional data first. We looked at data collection that is done by local EMS, fire, police, cities, counties, county health departments, as well as data from a state level, the state Virginia and North Carolina, their Department of Health and Human Services statistics, and finally data at a federal level from the CDC, the American Community Survey, the Census Bureau, and other sources. We then delved locally into the lived experience of issues in the Dan River region with key informant interviews, roundtables with community partners, surveys with many of the residents in the region. From all of this data, we looked across data sources, synthesizing the information and delving into both root causes of disparities in health outcomes themselves, the geography of health issues, and we assessed the current state of health in the community. Finally, looking at the gaps between community needs and resources, and identifying a few key recommendations for the Dan River region to address those issues. There were many organizations involved in this project across Pittsylvania County, Danville City, and Caswell County. You can see from this list, it's a broad group of folks who've come together around the issue of health equity in the Dan River region, from civic groups to health organizations, to municipal and county governance, all play a part in addressing health disparity. We conducted 23 key informant interviews, 7 public stakeholder roundtable sessions with 43 participants, 697 surveys were collected, both on paper and through the internet. And finally, more than 144 maps and 41 tables were compiled from administrative and jurisdictional data sources. We'll begin by talking about the status of community health in the Dan River region. Meredith.
The Dan River region has an estimated population of 125,000 residents, which are partially rural. The population has declined about 4% since the 2010 estimate, and most of this decline is accounted for in Danville, which lost about 15% of its residents during this time. The population decline is caused by and further affects many of the socioeconomic factors related to health issues that we're going to be discussing in this presentation.
The health issues that were mentioned by community members we spoke to were exactly the ones that we'd expect to be associated with poverty. One community leader told us, I mean, we really have those diseases that all of these things are a factor of: obesity, high blood pressure, cholesterol, diabetes, and they feed into this, you know, the heart disease, the stroke, all of these chronic conditions. And, you know, we have all of those. These chronic health issues usually tie back to the social determinants that we're going to discuss. An administrator we talked to said If you don't have access to fresh fruits and vegetables and those types of things, then you're just compounding your health problems going forward. If they're not actively engaged in sport, then the kids are overweight. Mental health issues were among the most mentioned chronic health problems. We heard about isolation, depression, schizophrenia, bipolar, substance abuse that cuts across categories of age and socioeconomic status. And people sounded the alarm, especially over kids' mental health and the stressors of poverty and mental health of the elderly. According to a health worker we talked to, there's a lot of depression. Like I said, you have a lot of elderly people and they're alone. They've lost a spouse and they're here by themselves, and it's everywhere we go.
High blood pressure and high cholesterol were among the most prevalent health conditions affecting the region. However, cancer and heart disease were among the most lethal, affecting about 10% of the population each. Here we have a map of cancer, and in the next one, we have the distribution of heart disease. As we go through the maps, you'll find that the highest rates of any of the factors are represented in blue, with the lowest rates represented in yellow. Obesity affects about 30% of the residents in the region, well over the state estimated rates. And corresponding with this finding, in 2019, Danville, Pittsylvania area was specifically distinguished as having the highest rates of diabetes in all of Virginia. Also among the top 3 or 4 leading causes of death was unintentional injuries, which includes overdoses. Here we can see where the Danville Police Department, Fire, and EMS responded to overdoses between 2019 and 2021, 68% of which involved opioids.
When we talk about the social determinants of health, we're really addressing the underlying conditions that cause negative health outcomes. Things like economic stability, social and community context, the neighborhood environment in which people live, the healthcare that they have access to, and education, the attainment of education by the population. One of the other factors that we'll include in our discussion of social determinants is also the condition of rurality. How rural a community is impacts many of the other underlying root causes.
The median income in the Dan River region ranged from about $37,000 to $47,000, with poverty affecting about 19% of the population. And as we can see, that is not distributed evenly.
Economic stability, as it's referred to on the social determinants chart, or income, is the obvious and inescapable driver of health equity in the Dan River region. Our methodical inquiry into all aspects of healthcare led us to this conclusion again and again. Primary care, mental health care, dental care, specialist services of all kinds, private health insurance, nutritious food, reliable transportation, safe housing, safe streets, parks, recreation, all are less available to poor people. As a result, some people don't get care. A health worker told us, if people do get sick, or they need even to just go to get checkups or anything like that, they feel like they don't have the funding nor the health insurance to be able to do so, so they don't go. And the most basic building blocks of healthcare are missing. For instance, many low-income people don't have a primary care doctor. Said one stakeholder, I think there are a lot of people walking around who haven't seen a doctor, unless it was in an ER. If you say, who's your primary care physician? What are you talking about, is what they ask. It turns out the syndromes of poverty affect every aspect of a person's life and place in the community. One observer told us, I don't think we've grasped the concept of when a person is living in poverty, it affects all of the decisions, the conditions which they are in, and how they think and how they view things. And another said, there are a lot of families in our communities that have to make that decision whether they're going to have food or the child is going to have food, against other essentials that they might have to take care of in their life. And it forces people to have to decide whether they're going to have food or housing or healthcare. And it gets worse because low-income people are apt to be low information people, and that's damaging to health. According to one of the people we interviewed, a person living in poverty will think, I only need to go when I have to, because if I go now, it's going to cost me money that I don't have. So as long as you're not hurting and in pain, we're okay.
The region is largely a vehicle-dependent community with limited access to public transportation, sidewalks, and greenways. Homes with no vehicles ranged from about 6% in Pittsylvania to over 16% in Danville, following patterns of racial distribution of non-white residents. About half of the Danville residents rent their home, compared to about a quarter in Pennsylvania and Caswell counties. And about half of the renters in Danville and Caswell were cost burdened by their housing, which means that they spent more than 30% of their income on housing expenses.
When we surveyed residents in the region, we asked about the condition of housing and the affordability of housing. Here we see agreement to disagreement on two of those points. Housing in good condition for people to live and find decent, safe places to live. Only about a third agree that there were sufficient good condition houses. 44% disagreed with the statement that affordable housing options for people making at least minimum wage were available. So we see that housing affordability is less in the region.
Health inequity is driven by inequitable access to essential social and economic resources like housing and like transportation. One frontline worker said, transportation is just in and of itself a barrier for everything, whether it's getting to work or getting to the doctor, getting to the store, transportation is a barrier. It's the overarching obstacle and social determinant having a decisive effect on access, not only to healthcare, but to social services, education, employment, recreation, food, and people's ability to connect with others in their communities. We were told that families without transportation always struggle just tenfold. And rurality is a multiplier of health equity. Danville has some public transportation resources, but quote, out in the county, there are a few options. And said one person, if you don't have transportation, you're done. Housing is a social determinant of health, almost as significant as transportation. We were told people living in substandard housing and the role that that plays in healthcare and people's ability to live healthy lives, we know that that's a contributing factor, lack of adequate housing, safe housing. Our informants described poor conditions, lack of maintenance, dirt floors, overcrowding, high rents and utility bills, mold, and homelessness. There are people that are still living in houses that pretty much you would refer to as having like a dirt floor in the house, where the house is unfinished and they still don't have indoor plumbing.
Violence is a public health issue that negatively impacts our physical and mental health and our overall well-being. And the unprecedented conditions of isolation, economic duress, psychological stress caused by the COVID-19 pandemic has resulted in increased rates of suicide, family violence, and community violence. The COVID-19 pandemic has also exacerbated health disparities for marginalized communities. Communities are also at a greater risk for exposure to violence. National news outlets have reported on concerns over increasing levels of violence during the pandemic, mainly citing gun violence and domestic violence at epidemic levels. However, public discourse on news outlets on violence during the pandemic varied locally compared to national news coverage, with some news outlets, especially within the first year of the pandemic, sharing positive news coverage as it related to lower levels of homicide and violent crime in the Dan River region. However, as the pandemic persisted, other news outlets locally reported on increased levels of violence. We conducted an additional set of community stakeholder interviews to have a better understanding of how health inequities and the COVID-19 pandemic impacted neighborhood violence in the Dan River region. Community stakeholders in this study included people from a diverse set of public health and public health related professions across the region. And to date, we've conducted 6 additional community stakeholder interviews. We conducted a thematic analysis of our community stakeholder interviews, and our primary research question was, how do community leaders, advocates, and stakeholders discuss neighborhood violence within the context of COVID-19 and health equity? From our community stakeholder interviews, 5 preliminary themes emerged. There are many factors that contribute to violence, including individual factors or behaviors like drug use, for example. But most community stakeholders discussed how the broader community and societal issues, such as access to affordable housing and employment, also contribute to violence in the Dan River region. Similarly, the consequences of violence are severe and is often described by stakeholders as a cycle of violence, meaning a vicious recurrence of violence within families and neighborhoods. Social determinants of health, where we live, work, and play, also shapes our health and risk for exposure to violence. And again, inequities in access to healthcare, job opportunities, and even transportation increases the risk for neighborhood violence. Similar to national news reports, community stakeholders felt that gun violence, homicides, domestic and family violence were the major types of violence of concern in the region. And solutions were always focused on being transparent, having transparency within agencies, and mutually beneficial collaborations. So a brief summary of our findings: the perceptions of violence and the impact of COVID-19 varied. Although some stakeholders stated that the Dan River region experienced low levels of violence during the COVID-19 pandemic, especially at the beginning, there is concern that the region may experience an increase. Equitable access to community resources in the Dan River region is essential to successfully provide the needed programs and services for violence prevention. Continuous efforts to address health equity in the Dan River region will also positively impact neighborhood violence prevention efforts. Also, building upon collective partnerships and coalitions is encouraged. Intersecting stakeholders' perspectives on the causes and consequences of violence in the Dan River region may offer opportunities for collective action.
We also received data from the Danville Police Department about where they had taken firearms into evidence. And several of the areas with the highest rates overlapped with areas with high rates of poverty, among other factors.
In our survey, we also found that there were varying perceptions at the community level on safety concerns and violence. We've circled in red some of community residents' perceptions that highlight this varying and contrasting views. Just for example, we know that over 60% of people who responded to our survey felt that they should be able to own guns for their personal protection, which might suggest concern for safety and wanting to be able to keep themselves and their family safe. But we also see that there are concerns around gun violence being a problem, with just 35.6% expressing concern, as well as there being a concern of almost 50% of drug use in the community. Our interview and focus group participants also had varying and conflicting perceptions of community safety. There's no consensus. One resident said, "I think the majority of people feel very safe." I think we're relatively a safe place for families. Another said, I think that safety, it just depends on who you ask, whether they feel safe or not. And a third voiced the contrary view. My perspective on crime is probably completely different than a big segment. And if you live in some of these less desirable areas, people are very afraid of crime. Gang activity was on a lot of individuals' minds. There's disagreement about the severity of it or how it manifests, but almost everybody's heard something about it. It might be getting better, or it might just be swept under the rug. One nonprofit staff member said, Danville does have a significant gang problem, and that was one of the things nobody wanted to talk about or acknowledge. That couldn't be. Little old Danville. Safety in rural areas also depends on your location and probably your race. A middle-class white professional who lives alone in a rural district stated, the only thing that ever comes to see me is a deer and some raccoons, so no, I'm not scared. But an elderly Black man living alone in a very different kind of rural neighborhood spoke of bullets flying every day.
The community has a variety of resources or assets. Fire protection was found to be quite high. Police protection, the perception was by 52.9% of the population answering our survey that there was adequate police protection throughout the region. We see that quality of schools, people were a little bit split on. 38% saying that the Dan River region has good quality public schools and 33.7% disagreeing with that statement. Public transportation we see is also split, with 39% disagreeing that there's sufficient public transportation. And finally, we see that 35% disagree that there are strong neighborhood watch programs throughout the area. In terms of exercise and recreation, the community felt very strongly that there are sufficient parks and open spaces for play and exercise, that there are organized athletic activities for youth, and that for the most part, there are free or low-cost opportunities for fun and leisure activities.
Many of the people we talked to said their communities are healthy environments to live in. One of the community residents says, I see everything on a rise. We're seeing more resources be out here now, and people are less reluctant to utilize those resources. So that's good news. Parks and recreation programs are some of the strongest resources. We heard many favorable comments about the facilities, about the programs available to residents, but these facilities are not available to all, and issues of equity arose. For one thing, it depends on your neighborhood. Focus group members said certain neighborhoods definitely have more access, like a basketball hoop or a jungle gym or something like that, and some don't. There are a ton of parks around Danville, said another, but the ones that are near the low income areas have been kind of let go. And we do have parks across the city that are very nice parks, but do people have the transportation to get there? Rural dwellers don't have access to the same recreational facilities as those in at least some city neighborhoods. A public administrator told us we're a rural county, and there's just not a lot of areas in other parts of the county that have that available to people to just be able to get out and walk, so that if they get out and walk, they have to walk on the road. And food resources are challenging. City and county dwellers alike told us their neighborhoods are food deserts, but in sheer distance, rural areas suffer the most. According to one county worker, there are parts of the county where it could take 30 minutes to get to one of these towns or to the city. So I would say that the majority of our county is probably a food desert. And the overabundance of dollar stores and convenience stores was particularly striking. A typical comment was, we have Dollar Generals everywhere. It affects people's health because they have cheap food. They don't necessarily have nutritious food, it's not there's not the availability of fresh fruits and vegetables. A lot of it is just grab and go type meals. As important as material resources like parks and grocery stores are social resources like community and social institutions. In this region, as elsewhere, these have declined in quality with less sense of community now. A resident told us, it used to be the neighbors knew each other. Now the doorbell rings, you look at your phone and see your Ring camera and say, oh, it's my neighbor. I ain't gonna answer. Churches, schools, and community centers help bring people together in the old days, and some still do, but they do less now, especially since the pandemic. And even they are not immune to issues of equity. I think we have some groups that are strong, said one community leader, like our volunteer fire departments are really strong. And you can tell that the people that are members of the fire department are cohesive. But there's sort of a racial divide there. You don't see a lot of African-American volunteer firefighters in our county.
Access to healthcare is a key social determinant. If you don't have sufficient doctors or specialists, sufficient dental facilities and vision facilities within a community, then you don't have access. In this area, we actually see that 82% of the population gets an annual physical and 61% get annual dental care.
About 90% of the population does have access to insurance, but those lacking insurance are consistently found in areas of higher poverty, concentrations of non-white residents, and poorer health outcomes.
Throughout our conversations, the blunt truth kept repeating itself that if you don't have insurance, you almost literally don't have access to health care. That's harmful to health. A healthcare administrator commented, I've known and worked with people who have allowed themselves to become really, really sick or in need. And the reason they didn't seek services was because they didn't know or think that they could get the service because they didn't have insurance. Those with insurance fall on a spectrum of coverage. At the top is a private insurance policy with excellent coverage, but even some who have insurance don't have excellent coverage. A focus group participant, definitely a middle-class person, told us, I have insurance and there are times when I don't take myself or take my children to a doctor because of the cost. And a nonprofit leader said, we often see the biggest issues with what we call the working poor. They have jobs and they have insurance, but they can't afford to pay a copay or afford their portion of the medication costs, and so they go without. Further along the spectrum is a gap into which fall some low to moderate income people. One focus group member spoke of people who make too much money to qualify for Medicaid and not enough money to pay for a private insurance. For those who are eligible, Medicaid is a bridge over many of the obstacles we've discussed. A local resident said, if you got Medicaid, you can go anywhere. You don't have to pay anything. That may be an exaggeration, and there are drawbacks, among them limits to what doctors will accept and limits to what Medicaid will cover. Another resident told us, I was on Medicaid and I went to a doctor and I asked her, can I get a mammogram? She told me no, and I'm like, okay, I have a medical history of this, but she didn't take that into consideration. And I felt like if I had had private insurance, maybe she would have looked into that more deeply than if you're on Medicaid.
As Bruce mentioned earlier, rurality itself is a social determinant, with distances between food and medical care and people's homes being quite broad. We also see that transportation, housing costs, and housing quality are an issue in these regions.
In the Dan River region, rurality can be as powerful a driver of health inequity as income. We were told, as a rural county, people are very spread out. It makes it difficult for people to get the care they need or access to the grocery store or anything because they're not within walking distance and there's not a lot of opportunities in the outer reaches of the county. The social and physical conditions of rural life affect every dimension of health equity. There are fewer doctors and they're harder to get to. Long distances make transportation harder. Social isolation is more pronounced. Internet access is poor. There are limited options for healthy food. A local resident said, we are very rural in most portions of the county and we have no public transportation. So if you don't have a car, or you don't have somebody to transport you back and forth to the town or the city in order to get healthcare and food and things like that, you're going to have a very difficult time. Another said, in the very rural parts of the county, it feels much more kind of isolated. You're on your own type of thing, you know, and people live further apart in those areas. Rural areas contain pockets of poverty that present special challenges in terms of both access and attitudes. A county worker spoke of some of the very remote communities. They're very deeply rural back there, and there's a lot of poverty out there, and it's a lot of, you know, out there, it's a constant thing to try to build trust in the relationship, to break down that barrier, to help people get care. They're very hesitant to reach out or to accept that.
When talking about health inequality, we really also have to talk about the condition of structural racism. Poverty alone can't explain some of the differences that we see between groups.
The region is mostly white at 63% and Black or African American at 32%. Only about 3.4% of the population identifies as Hispanic or Latinx, and Black residents are highly concentrated in the Yanceyville area and particular neighborhoods around Danville.
We disaggregated our survey data on the basis of African American versus white, and we see that there are some very stark differences. We asked in the past 12 months, how much has each of the following issues contributed to health problems experienced by you or anyone that you live with? We see that there are disproportionate responses by African Americans and whites to not having enough money to pay medical bills, not having enough dental insurance, not having money for rent or mortgage, not having health insurance, being unable to visit a specialist, and no money for food. We do see that there's a shift when we get to questions around physical harm and perceptions of safety, with whites feeling that they are more at risk for physical harm and that they have no safe place to live. We disaggregated as well this question on whether or not people believed that some groups get better healthcare than other groups on the basis of race and ethnicity. We see that differences were also found by where you live, with about equal proportion of Danville residents, white and Black, thinking that some people get better healthcare. But Caswell County, we see that there's a stark difference, with 92% of African Americans believing that some people get better healthcare versus 85% of white residents. In Pittsylvania County, it was the reverse of that, with 67% of African American respondents saying that some people get better healthcare and 74% of whites feeling that way. Very telling was the experience of discrimination by race and ethnicity. We saw that you were twice as likely to see African Americans experiencing discrimination in healthcare than white respondents. 25% of African Americans versus 20% of whites felt that they were discriminated against by community agencies or organizations. Whites, on the other hand, felt that town, city, and county governments and other settings discriminated against them.
We've talked a lot about poverty and geography, but issues of racial equity cut across these discussions of poverty and geography. In the Dan River region, the poor and the uninsured are disproportionately Black. We heard comments such as our low-income areas are primarily African-American communities. And a lot of the African-Americans are living in the poorer or low income, so I think there's just that division there. Our research shows that race is as strong a predictor of health inequity as income, and that's harmful to health. Comments we heard in our roundtable discussions. Normally, when we're talking about the health equity on different levels, it's based on minority. And there's a feeling of inequity when it comes to the quality of care or the services that are provided based on, the race of the individual going for services. For better or worse, the pandemic laid bare some of the racial inequities in the healthcare system. Our community leaders said, one community leader said, hopefully, one of the things that came out of the pandemic is people start talking about health disparities and racial disparities and all this stuff. We saw racial inequity not only in the delivery of healthcare, but in healthcare employment as well. A person who studies the workforce gave us an example. That's a space where we see some gender inequity, race inequity. As we looked at the clinical healthcare pathway, our CNA population does not look like our RN population. And of course, issues of racial inequity pervade the whole society. People spoke of segregation physically, socially, and in the school system. One said, I feel like our African-American communities and our white communities are very separated. And another commented, you have a higher percentage of one group in socially academic advanced classes, and then you have other kids that are not. And when you look at the demographic makeup of kids who are in that, they tend to be all of one race. We're separating our kids based on race. Some pointed to broad issues of history, politics, culture. Speaking of her feelings of vulnerability, one focus group member observed, I think the fact that in Danville, we still have a ton of huge Confederate flags flying around. And another said, some of our leaders are the least equipped to really realize what's going on. They're so removed from that world that they can't get it. Race and rurality intersect, just as race and income do. We learned that some rural communities are segregated racially, just as urban ones are. Said one rural resident, out in the county, poor Black people and poor white people are much more separate. But as an example of the thinking process that we sometimes see, some don't see race as the issue. One person said, this is a rural issue. We don't really see this as a racial issue per se, at least not in our experience. Residents say that across the board, the Dan River region is falling behind in the struggle for health equity. We're told, as a community, I don't think we've really just focused on equity. And as far as health equity, we haven't been focusing on that. Some of the political and nonprofit leadership are not helping either, we were told. One nonprofit worker said, a significant portion of our board that have the influence are not so crazy about studying these issues. Some people consider that social work, and why the hell are we involved in that? And some people are just not comfortable talking about the racial dimensions of health equity. For whatever reason, we cannot talk about race without folks really polarizing. I don't think we understand how to have that conversation, or we're struggling on having that conversation.
Almost all of the tracts within the Dan River region fell below the estimated life expectancy rate for Virginia, North Carolina, and the United States. When compared to the previously seen maps, this one appears to be the inverse, showing the lowest life expectancy where there are the highest rates of poverty, poor health outcomes, and non-white populations.
We took all of the data that we had collected and put it into a matrix, a database, looking for which factors were most correlated with negative health outcomes and life expectancy. From this, we built a model for the Dan River region, a health equity score that ranks communities against each other, neighborhoods against each other within the region itself. In this map, you can see that the neighborhoods in East and Southeast Danville had the lowest health equity scores. This is the causal factors that are related to lower life expectancy. We see that just north of Danville in Pittsylvania County around Dry Fork area, we had the highest equity scores with the highest and best outcomes. This kind of equity score can be used to pinpoint and target resources for addressing inequalities. As we move upstream, we did have recommendations from community participants, interviewees, focus group participants, and survey respondents about what to do about health inequalities. Universal health care coverage came up as one of the possible solutions. Better access to insurance might mean better access to care. Funding more specialists within the region so that people don't have to go to Raleigh or other parts of Virginia to be able to get specialized care. Better transportation choices, not just in the Danville area, but throughout the region, were a recommendation. Sometimes taking clinics and care to the people were suggested through mobile clinics and outreach into isolated areas. The food system and housing affordability were two areas where there were many recommendations on how to improve the conditions in which people are living. And finally, encouraging more civic caring and community resilience through the existing social and cultural resources within the communities. Survey respondents answered questions also related to recommendations. From this list, we can see that they were asked to rate on the basis of high, moderate, or low importance each of these following issues. We found that healthcare system navigation came out on top, the recommendation being that there be more access to care coordination, navigation, and community health workers. Affordable housing was a very close second. Providing more affordable quality housing means better environmental conditions for those living in low-income communities. Looking at health policy consideration in all aspects of community and municipal life. How do we get health in all policies types of approaches throughout the region? Finally, healthcare service access itself was of high importance to many who responded. We can divide our findings into 5 key areas or key issues that impact all of the Dan River region. Racial disparities in healthcare, poverty as a root cause of disparity, housing quality, availability, and cost, transportation access, and access to insurance and health systems. When we disaggregate these 5 key issues, we come up with about 13 suggested actions or recommendations. First, increase participation in the current and expanded federal safety net programs, both in Virginia and in North Carolina. Explore the feasibility of programs like guaranteed income that provides a basic cost of living. Increase the number of living wage jobs within the region. Fund affordable rental housing units. Petition for local inclusionary zoning ordinances and eliminate single family zoning preference so that there's better development of multifamily and low-income options. Expand housing repair and weatherization programs that already exist in the region to improve housing quality. Develop healthy homes criteria and minimum housing standards within each of the jurisdictional areas. Promote the use of Danville's mass transit system. Increasing ridership will increase availability of new routes. Encourage increased ridership in half-fare programs and handy van services that already exist as well. subsidize rides to large employers, health systems, or retail centers, support and expand the regional engagement to advance community health or REACH partnership, which provides community health workers and resource navigation. Assist members of the public in accessing federal insurance programs like Medicare and Medicaid by expanding or transforming those systems. Finally, create a regional community care network for those who still fall through the cracks in insurance provided by federal or private insurers, and through this network, provide care to the uninsured. You can find the copy of our 462-page report at chcs.uncg.edu. This report is open and accessible to everyone in the community in an easy to read PDF format with over 163 maps and 44 tables, visualizing data in an easy to understand manner. We've also included a set of 7 pages worth of infographics breaking down key findings into graphical, easy to interpret data points. This can be found at vengage.net/PL/capital GRDINDQNBJ4. I understand that's a difficult link, but we'll make sure that it's available to you online. Finally, there's an interactive website where you can explore the maps in the data collection, looking at 2017 comparison to 2021 in most of the data that's available. This allows you to explore the earlier findings of the 2017 Health Equity Report compared against today's findings and see where there have been gains or losses in health outcomes. The website breaks down by population and health status, social determinants of health, inequalities in health, the health equity ranking, and recommendations. It's found at go.uncg.edu/health equity assessment. Thank you so much for watching this video of our presentation. If you have any questions, please feel free to email us at chcs@uncg.edu for follow-up. Thank you.